So, good afternoon, ladies and gentlemen. My name is Alessandra Fanciulli from the Medical University of Innsbruck, and it is my pleasure today to talk about how to ride the blood pressure roller coaster that people with living with MSA might face. So, how does it feel to have neurogenic orthostatic hypotension? People describe this with symptoms of end organ hypoperfusion. So, like lightheadedness, dizziness, or visual changes due to retinal hypoperfusion, sometimes troubles concentrating, or pain in the shoulder and in the neck. This is what doctors call cold anger pain, or still less specifically, fatigue or weakness that occur when standing from sitting or when walking, for example, up a hill or climbing stairs, produce an overwhelming urge to sit down and, when severe, can lead to fainting and falls. In fact, oftentimes in medicine, when a fall is not explained by a slip or a trip, should be considered as a syncope, an unexplained syncope, and ascertained as such, especially if exacerbated in MSA setting by large meals, heat exposure, dehydration, alcohol consumption, or physical exercise. By definition, neurogenic OH is a fall in blood pressure. You see this thick blue line in the bottom part of the graph, more than 20 to 10 millimeter quicksilver within 3 minutes in the upright position, so developing quite soon after you stand up, with an insufficient heart rate to increase, which is unable to compensate this falling blood pressure. How many people living with MSA suffer from neurogenic orthostatic hypotension? Studies say that the prevalence of neurogenic OH in MSA ranges from 52%, so every second person with MSA, to 83%. So this is a very frequent problem. And neurogenic OH typically makes its most troubles here in the established phase of the disease is, let's say, less troublesome with a person has lost the ability to walk, but might also develop in the so-called premotor or prodromal stage of the disease. In fact, in the latest revision of the MSA diagnosis criteria, neurogenic OH, as you see here, is an entry criterion for the diagnosis of this research category, which is possible prodromal MSA. And studies from Innsbruck, from our many talented Dr. Lies, showed that, in fact, male sex is associated with more severe neurogenic orthostatic hypotension. So, male people are 5 times more prone to develop severe symptoms of orthostatic hypotension. And this has indeed a highly significant impact on activity of daily living. This is a study from the past decade from a large interventional trial, which shows that OH has a major impact on different activities of daily living. For example, requiring a short standing, like when you're brushing your teeth in the morning, or standing for a long time because you're cooking your lunch, when you walk for a short time because you're doing some errands, but because you're cleaning your house, or walking for a long time because you're doing some errands. But neurogenic OH also affects gait performance in people with Parkinsonism. In this study from Innsbruck, using a gait sensor, we could see that neurogenic OH has a negative impact on gait velocity, on the maximal toe clearance, so how good your step is, and so, and how likely on the other end is that you will slip or trip, and also on the stride length. In fact, there is an increased risk of falls and syncope associated with orthostatic hypotension. But the effect is not only on syncope and movement, but also on other aspects of our daily life. For example, cognitive performance. Studies from the Bologna colleagues from Pietro Boraldi, as you see here, showed that standing has a major impact on cognitive performance in people with neurogenic OH. Why is this the case? Because in the supine position, blood pressure might stay within the normal range, and so cerebral perfusion is warranted. But when in the upright position, blood pressure gets below the so-called cerebral autoregulatory range, which is this blood pressure range where the blood vessel can secure an adequate perfusion of the brain, then symptoms of orthostatic hypotension might develop due to this hyperperfusion. And this was a study from the New York group, which showed that blood pressure values below 90 are particularly meaningful in predicting this kind of symptoms. Studies from our group, very recent, published last year, also showed a connection between orthostatic hypotension and pain. So we have found in a community-based survey to which you might have contributed and for which we're very thankful that up to 85%, 87% of people living with MSA report painful sensation, most frequently localized in the neck and shoulders. And when looking at factors associated with regional pain in MSA, we found indeed that pain in the neck and shoulders is associated with orthostatic intolerance, so orthostatic hypotension. Again, we are talking of this so-called co-tanga pain, which is due to hypotension-induced muscular ischemia and might occur in classic OH, but also in the variants which might be frequent in MSA, like postprandial hypotension or exercise-induced hypotension. So why do people with MSA develop neurogenic OH? So where is the problem? There is a degeneration of the central part, so within the brain, within the lower part of the brain, of the nuclei regulating the autonomic nervous system. There is a degeneration of the central autonomic nervous system. At advanced disease stages, there might be also some degeneration of the peripheral of the nerves controlling the effector organs, and there are some non-neurogenic mechanisms which might impact on blood pressure regulation. And these are, for example, anemia. So if you have a low hemoglobin content, if you have hypovolemia, so your blood volume is reduced, or if you are taking blood pressure lowering drugs. Which are the blood pressure lowering drugs? Not only the classical antihypertensive drugs, which the doctor might give you if you have high blood pressure, but also many drugs that neurologists prescribe to treat motor and non-motor symptoms. For example, dopaminergic drugs for Parkinsonism, but also drugs to support against depression, or to help you sleep better, like if trazodone, or drugs to stay a bit calmer or treat REM sleep behavior disorders. This is the case of neuroleptics or benzodiazepines, or to treat pain, like in the case of opioids. So when we decided it's time to treat neurogenic OH, which is the therapeutic goal that doctors and people living with MSA should pursue together. Warrant autonomy in daily living, so that to warrant the highest possible level of quality of life and prevent life-threatening events like syncope and associated injurious falls. So what should people do? The first step is not to put something on top, but treat exacerbating factor. So are there any intercurrent infections? Oftentimes it is about urinary tract infections or lung infections. Is there an anemia? So is, for example, iron supplementation necessary, or it is about the kidney, which is not stimulating blood production enough with erythropoietin? This you can talk to your doctor. Reintegrate fluids. Oftentimes, people lose a bit the sense of thirst and so do not drink enough during the day. Or, and this is something that doctors should to help you to do, remove and reduce the amount of blood pressure lowering drugs in your medication schedule. Step number two is the implementation of behavioral and non-pharmacological measures. These are very important because are in the hands of people living with MSA. They are not doctor driven. So which are the do's? Important things are the so-called counter pressure maneuvers. These are isometric exercises or muscle tensing, which help you to stabilize the blood pressure when you go into upright position. Some might not be well practical in MSA, but for example, rhythmically clenching the fist is a low-hanging fruit for you to stabilize your blood pressure if you need to to stand still for a longer time. It might be the case that the hardest moment of the day, what concerns OH symptoms, is in fact the early morning. This we oftentimes observe in clinical practice. And then there are again some interesting non pharmacological things to do. So, for example, activate your muscle groups before standing up. You might start, as you see here in the first line, with simple movements of the wrist, then mobilize the elbows, and then move to the lower limbs. So mobilizing first your feet, then your knees, then your hips. For example, riding the bike in the air. And then when this feels somehow so acceptable and better, you might change in the sitting position, and in the sitting position again continue activating muscle groups before eventually standing up. So even though we are used to stand up and go in the morning, it might be good at that moment to take 5 minutes time to activate your muscles before standing up. This might help mitigate symptoms of OH in the early morning. Another very important tip is to warrant an adequate fluid and salt intake and raise the upper part of your bed while you're sleeping. There is an ongoing studies from the colleagues from the Nijmegen and Leiden University, which I hope we'll see published soon, which is in fact investigating the tolerability and efficacy of head-up tilted sleeping at different angles to treat nocturnal hypertension and improve early morning orthostatic intolerance. Another option are compression garments, especially abdominal binders. In Innsbruck, we ran this study many years ago showing that this is efficacious in Parkinson's disease in reducing the blood pressure fall and raising symptoms of orthostatic intolerance, and are investigating this again in MSA also based on some sensor-based analysis. Which are the don'ts? What should you avoid? Heat exposure, even though this might feel pleasant in summer, this is not good for you, for your blood pressure, because it induces vasodilation and perspiration, but also large meals, because then all the bloods will go to your belly to digest. And likewise, alcohol consumption, because this also will cause vasodilation, lower your blood pressure, and foster urine excretion. Oftentimes, a pharmacological therapy will be needed, and then there are some pharmacological targets which you might consider. I like very much the scheme prepared by Dr. Palmer and Dr. Kaufman, which clearly explains which are the pharmacological targets. And you see here one target is from the preganglionic, so from the synapses connecting the central to the peripheral autonomic nervous system. This synapses is a cholinergic one, and so we might borrow a medication which we use in other settings to enhance this transmission, for example, with pyridostigmine. Or we concentrate on the so-called noradrenergic transmission. This is the sympathetic terminal. And so what we might do is administer droxidopa, which is a noradrenaline precursor, is available both in the US and in Asian countries for treating neurogenic OH. European people do not have this luck. or stimulating directly the so-called alpha-1 adrenoreceptors. Those are receptors placed on the blood vessels and inducing this vasoconstriction. These are stimulated with a classical midodrine. This is one of the most frequently used medication to treat OH, or the older ethylephrine, which is available in some European countries instead. Another option is to expand the plasmatic volume, and this is achieved with fludrocortisone, which is a synthetic mineralocorticoid analog. Sometimes combined pharmacotherapy is needed, and so what is usually done in clinical practice is a combination of a sympathomimetic agent, for example, midodrine, with fludrocortisone. But what is on the horizon for novel treatments? An important pharmacological targets are noradrenaline transporter blockers. These are atomoxetine, which is borrowed from the psychiatric field born as an antidepressive drug, or a synthetic analog, so a selective noradrenaline transporter blocker, which is ampreloxetine. Starting from atomoxetine, unfortunately, we have, let's say, bad news. While former studies showed that atomoxetine can raise the blood pressure in people with OH, a more recent study done at Vanderbilt, so by people who are really knowledgeable and expert on the autonomic nervous field, showed that atomoxetine administration in a blinded fashion did not improve sufficiently symptoms of orthostatic hypotension. However, and this is important for our interpretation, this group of people who participated in this study were both MSA people and people with Parkinson's disease and PAF. This is important, and I will explain you in a while why. Another study also using this noradrenaline transporter blocker, another approach which is industry driven, is with ampreloxetine. Phase 2 trials indeed showed that ampreloxetine efficaciously improved symptoms of orthostatic hypotension in people with Parkinson's disease and MSA. And in recent years, bigger studies, a so-called phase 3 study, was launched, including people with Parkinson's disease, pure autonomic failure, which is another disorders, and MSA. And unfortunately, this study was negative. However, when having a look at the subgroups, so people with PD or people with MSA, this group of researchers found that the impact of ampreloxetine on symptoms of orthostatic hypotension was actually favorable in people with MSA. Now, you might ask yourself, yes, but why should noradrenaline transporter blockers work specifically for MSA? Then we need to go back to neurophysiology. What does noradrenaline do to the autonomic nervous system? At peripheral level, noradrenaline produces vasoconstriction, so a raise in blood pressure. However, due to negative feedback loops which we have in our body and help us to self-regulate all the time, noradrenaline stimulating in the central nervous system, so a specific receptor, produce vasodilation. This is an activation and shutting off the same mechanism contemporarily to prevent exaggerated responses. And this is also, for example, the rationale for using clonidine in the treatment of high blood pressure. Now, in MSA, since we have a central degeneration of the autonomic nervous system, the effect of noradrenaline, which we are going to stimulate, blocking the noradrenaline transporter, we increase the half-life of noradrenaline. The neat effect, which will be the peripheral one, so driving vasoconstriction and a raise in blood pressure. So this is the pharmacological rationale. But in the treatment of cardiovascular autonomic failure, we have a big elephant in the room, which causes severe roller coasters, and this is supine and nocturnal hypertension. You see, in this person living with MSA, you have a very frustrating and difficult to treat combination of sky high and very low blood pressure levels. It really looks like a roller coaster, which, when you pinpoint this as a physician, requires much caution and additional therapeutic measures. But why do we need to treat this? So why does the doctor might consider why might the doctor consider to treat supine hypertension? An important aspect is if you have high blood pressure, your kidney will filter more urine overnight and produce dehydration. So, if you treat supine and nocturnal hypertension, this might ameliorate your lower the number of your nocturnal toilet visits and reduce orthostatic hypotension the day after. It might help prevent hypertensive emergencies, so these phases of very high blood pressure, which might be dangerous, and eventually reduce end organ damage, so this small damage which is given by high blood pressure. On the other hand, we need to stay very, very cautious because every drug which I give to lower the blood pressure overnight might worsen orthostatic hypotension the day after. So, what to do? Some recommendations have been released by the European Federation of Autonomic Society and American Autonomic Society, and basically recommend to distinguish among different degrees of supine hypertension. So if you have known that the most important thing will be to implement preventive measures. So, for example, avoid the supine position during daytime when people are, for example, taking pressor agents like midodrine, droxidopa, or others. Avoid drugs which might interfere with noradrenaline transmissions, and some are painkillers, some are drugs which we use to treat depression, like duloxetine or venlafaxine. Water, we're taught during daytime it is important to drink water to stabilize and increase blood pressure, but for the same reason, it is not advisable to have a high water intake in the second half of the day because this will contribute to nocturnal hypertension. And among all the pressor agents that I might give to raise the blood pressure, I should try to use those which have a short duration of effect so that I don't influence supine hypertension. And so, for example, prefer midodrine over fludrocortisone, which has a long duration of effect. Sometimes might be needed to give higher dosages of midodrine in the morning, but not in the afternoon, because we have observed sometimes that the blood pressure tends to raise spontaneously during daytime, so that in the afternoon it might not be needed to give midodrine. An important thing, treat painful conditions which also impact on blood pressure regulation. Pyridostigmine is a drug which you might consider to treat both orthostatic hypotension and supine hypertension. If there is mild supine hypertension, so between 140 and 160 millimeter quicksilver, then no pharmacological measures might be advised. For example, sleeping with a head up in a head up tilted position, or take a small snack at bedtime. This will kind of provoke postprandial hypotension and help you to cope with mild degrees of nocturnal hypertension. If you have an enteral feeding per gastrostomy, an idea might be to schedule the biggest caloric intake at nighttime, because this will again cause some degree of postprandial hypotension. There were case reports which leveraged this approach. Which are other options? Again, studies from the Vanderbilt show that even simple, so grandma's remedies might be helpful to treat nocturnal hypertension, like heat exposure. So with a local passive heat, be it a warming bag or a warming blanket, produce a local vasodilation, and as you see here, lower the blood pressure during nighttime, as this would not happen if the people were not exposed. Another important study from the Vanderbilt showed that also continuous positive airway pressure therapy, so the so-called CPAP therapy, might help to lower supine hypertension in people with autonomic failure, including MSA. The colleagues postulated that the effect of CPAP therapy on the blood pressure is similar to the effect that you have during Valsalva maneuver. So if you expire against the pressure, which causes, as you see here, a falling blood pressure. However, there is an interesting additional study from the group of Satish Raj which shows some connection here because they showed that when people with orthostatic hypotension, including MSA, breathe CO2 enriched air, they have a dose dependent reduction of the orthostatic blood pressure fall. So they have an increase in blood pressure. And this might be relevant for nocturnal hypertension because it is oftentimes described that in people with MSA, there might be some sleep disordered breathing, obstructive sleep apnea, central driven sleep apnea, and this might increase CO2 concentration and drive this increase in blood pressure, which we oftentimes observe. Sometimes pharmacological measures are really needed because the blood pressure stays sky high all the time. And so the approach here is to schedule to give some short-acting antihypertensive drugs at bedtime, not during daytime. And these are the drugs you see listed here, which have been investigated in, I must say, rather small studies, but that might be considered on an individual basis if nocturnal and supine hypertension are a considerable problem. So, summarizing, neurogenic orthostatic hypertension affects the majority of people living with MSA. It impacts on activities of daily living, motor performance, and other core features such as cognition and pain. Treatment relies on a stepwise implementation of non-pharmacological and pharmacological strategies, and novel non-pharmacological measures and drug targets would hopefully help to improve the quality of life of affected individuals and prevent life-threatening complications such as syncope and falls. When this is a more warrant for physicians, but also for you as a person living with MSA for self-monitoring yourself, monitor for concomitant supine and nocturnal hypertension. Talk about this to your physician because these are likewise treated in a stepwise fashion with preventive, non-pharmacological and pharmacological measures. This was my last slide. I would like to take the chance to acknowledge the hard work of the people dedicated to MSA care and research in Innsbruck, but also worldwide, to MSA advocacies, which do a hard work likewise in raising the awareness for this important disease. And let me acknowledge you for your brave fight against this disease. Thank you.